Dr. Hatch, I know you have the slides that have the intro for next month's session. I also have those slides. So the slides that are on the screen right now are Rachel's, and it doesn't have that slide about the July session. So if you should be able to share your screen if you want to share it just for the intro, and then you can press stop share, and then it should go back to Rachel's slides when you're done with your intro.
So I didn't log in, Chase did, so I don't have access to that right now.
Okay, I can share it on the screen and I can advance it as you're talking, and then you don't have to worry about it.
That would be great.
Yeah, absolutely.
John, am I good to admit all the people in the waiting room?
Yes, well, I'll go ahead and do that. Or Raven, can you do that?
Well, I can do it. I was just making sure I was good to go.
Okay. Yeah.
Thanks.
And so we're all ready to roll?
Yep.
Okay. All right. Well, good afternoon, everybody, and welcome to the Primary Care Innovations webinar series. I want to first of all give a plug for our session that is coming up next. So Gianna, if you could get that up there for us. And
should be up there now.
I'm not seeing it, I'm sorry. I apologize, everybody. I am new to doing these things. I don't see either. Okay, so we'll try to get that to you later on then. So then moving on with today's session. So before we start, I had a couple housekeeping items. First of all, during the session, please mute your audio. And we will do that automatically, but you will be able to unmute yourself at some point. So just please do that when it's time for talking. We also plan to record this so that other people can watch it later. And if you would rather not have your image videotaped and part of that, then please just turn off your camera. We will have questions at the end, and if you have questions that come up and you want to enter them in chat while we're going, then I'll look at those towards the end and help that guide the questions that we have, or you can just hold them until the end and then bring them up then. You will get 1 hour of CME credit for this, and in order to do that, you have to complete the evaluation. So you should have already gotten a link for that in your email, and you'll also receive an email again later with the link to do that. Okay, so today we are thrilled to have Dr. Shattuck and Vogel Anderson from the College of Pharmacy, as well as Sally Walker, who is a nurse here at Shands, and they'll be presenting their innovative team-based approach to hypertension management. Dr. Shattuck is a first-year pharmacy resident at the University of Florida College of Pharmacy. She earned her Bachelor of Science and Doctor of Pharmacy degrees here at UF, and her professional interests are chronic disease management and transitions of care. Dr. Vogel Anderson is a UF College of Pharmacy faculty member and the program director for the first ASHP accredited PGY1, a lot of letters, sorry, pharmacy residency program at UF, which she established in 2012. And her research interests include anticoagulation therapy, pharmacist-physician collaboration, and improving medication management at transition points in care. And finally, Sally Walker is a registered nurse and health coach at UF Shands. She collaborates with patients and their primary care providers to provide a model of care that ensures the delivery of quality, efficient, and cost-effective healthcare services, and it integrates evidence-based care that monitors patient progress and promotes early intervention in acute care situations. So thank you all very much for joining us today, and take it away.
All right, well, thank you so much for that introduction. I hope everyone can hear me. Can I get a thumbs up if you can hear me? Okay, cool. Well, thank you so much for joining us for this webinar. Like they mentioned, my name is Rachel Shattuck, and I'm a pharmacy resident here at the University of Florida College of Pharmacy. Today, I will be presenting on our interdisciplinary hypertension team at the UF Health Internal Medicine Clinic at the Medical Plaza. I did want to mention that my colleagues, Dr. Catherine Vogel-Anderson and Sally Walker, will also be on the call, so they'll be available for questions at the end if needed. And then Dr. Melanie Hagen is our physician champion for this team, so also wanted to give her a shout out as well. So neither myself nor any of my colleagues have anything to disclose in regards to conflicts of interest on this topic. And the learning objectives for today's presentation are to review the updated definitions and goals from the 2017 American Heart Association and American College of Cardiology hypertension guidelines. We'll also define the role of an interdisciplinary team in the treatment of hypertension and discuss literature and evidence supporting the use of an interdisciplinary team for the treatment of hypertension. Lastly, we'll share some of the results and future directions of an interdisciplinary hypertension team from our UF Health Internal Medicine Clinic. So before we get started, I think it would be important to review the 2017 American Heart Association and American College of Cardiology hypertension guidelines because the definition of high blood pressure has recently changed. I also wanted to mention that when classifying someone as normotensive versus hypertensive, the guidelines recommend using at least 2 blood pressure readings taken on 2 separate occasions. And this is because there are a lot of factors that can influence blood pressure, whether it be mood or stress, or even just the position of the patient's body when they're getting their blood pressure reading. So making treatment decisions based off of one reading alone is not ideal, but sometimes is necessary. So the guidelines define stage 1 hypertension as a systolic blood pressure of 130 to 139 millimeters of mercury, or a diastolic blood pressure of 80 to 89 millimeters of mercury. They define stage 2 hypertension as a systolic blood pressure of greater than or equal to 140 millimeters of mercury, or a diastolic blood pressure of greater than or equal to 90 millimeters of mercury. So then the next question to address is, why is it important to assess blood pressure and to screen for hypertension? And the answer is really because uncontrolled hypertension can increase the risk of heart disease, stroke, and myocardial infarction. Now, heart disease and stroke are some of the leading causes of death in the United States, and so we really want to prevent these events from occurring in the first place. And one way we can do that is to identify risk factors and treat them appropriately. So according to some data from the CDC, about 108 million adults, or 45% of the population, have hypertension, which they defined as a systolic blood pressure of greater than or equal to 130 millimeters of mercury, a diastolic blood pressure of greater than or equal to 80 millimeters of mercury, or anyone who is taking a medication for hypertension. In addition, only about 1 in 4 adults have their hypertension under control, and about half of adults with uncontrolled hypertension either aren't prescribed or aren't taking their blood pressure medications for whatever reason. So I think these numbers show us that on a national level, there is definitely room for improvement when it comes to the treatment of hypertension, and that a team-based approach may be helpful in improving some of these statistics that we see here. So going back to those guidelines that I mentioned earlier, the blood pressure goal for patients who have hypertension is less than 130 over 80 millimeters of mercury. This goal is for patients who have known cardiovascular disease or a high risk of having an ASCVD event, but also for patients who do not have known cardiovascular disease or are considered low risk for having an ASCVD event. The evidence is a little bit stronger to support this recommendation in a patient who has known cardiovascular disease to prevent an event from occurring. However, they still use this general goal for all patients. And this is a good time to mention that we always want to treat the patient and not the number. So although we do know that the evidence supports treating to a target of less than 130 over 80, if the patient's unable to tolerate that blood pressure due to side effects, or maybe it's the number of medications they're taking or cost, we do want to keep that in mind as well. So we want to take a very patient-specific approach and not just blindly treat to this goal of less than 130 over 80 for all patients. Now, when it comes to monitoring blood pressure, the 2017 ACC/AHA guidelines recommend using systematic strategies such as home blood pressure monitoring, so having the patient monitor their blood pressure at home and bringing those readings into clinic for further information. They also recommend using telehealth, which has definitely gotten a lot more attention recently, and then also using a team-based care approach. So this is the recommendation that kind of drove the creation of the hypertension team here at our clinic as a way to facilitate this systematic approach to monitoring in lines with the guideline recommendations. Now for follow-up, the guidelines recommend monthly follow-up for patients who have uncontrolled blood pressure to assess for adherence and then also to assess for response to treatment changes. And if you imagine monthly follow-up for patients who have hypertension, if the primary care physician is the only one managing the hypertension, that can put a huge burden on that provider. So you could see the benefit of adding other disciplines to the team to help during this monitoring period to allow for monthly follow-up to be in line with the guidelines, but then also not put too much burden on the primary care physician. So incorporating multiple disciplines into this team-based care approach can help us appropriately manage our patients who have uncontrolled hypertension until we get them to that controlled status. So now that we've reviewed the guidelines, the next thing I want to do is review some of the literature that's out there to support the use of an interdisciplinary hypertension team for the treatment of hypertension. The first study that we'll look at is a meta-analysis that was published by Carter et al. In the Archives of Internal Medicine in 2009. This was a meta-analysis that was done to determine the potency of several different interventions for blood pressure control that involved either a nurse working with a physician or a pharmacist working with a physician. They included 37 different studies in this meta-analysis, which included quasi-randomized controlled trials, controlled before-after studies, patient randomized trials, and then also cluster randomized trials. The Medline database search went on from January 1st, 1970 to February 5th, 2009. So you can see there's a wide range of dates there. And you have to imagine that the standard of care likely changed throughout that time period, but it is nice to know that they looked at a wide date range to get as many studies as they could to include in this meta-analysis. And they divided the studies into 3 separate categories. The first category was nursing interventions. So this was a nurse working in the primary care office directly with the primary care physician making interventions for blood pressure in patients who had uncontrolled hypertension. The second group was community pharmacist interventions. So this was a pharmacist working in the community setting, either calling or faxing the primary care providers, making recommendations or making other interventions to help improve blood pressure control. And then the third group was clinical pharmacist interventions in the primary care office. So this was a pharmacist housed in the primary care physician's office that was working directly with the physician to make recommendations or other interventions to help improve blood pressure. So they looked at a lot of different interventions, a lot of different studies, and mainly what they found was when they looked at the change in systolic blood pressure, the interventions that were most commonly associated with a greater reduction included when a pharmacist recommended a medication to a physician. So anytime a pharmacist recommended a change, whether that was in the community setting or in the primary care office setting, they saw an average reduction in systolic blood pressure of 27.21 millimeters of mercury. Anytime lifestyle modification counseling was performed, and this could have been done by a nurse or a pharmacist working with a physician, they saw a decrease in systolic blood pressure of 12.63 millimeters of mercury. And then anytime a treatment algorithm was used, so this was a form that they decided on before the study even started, where they included a nurse or a pharmacist in the protocol and spelled out specific interventions that they were going to make depending on the specific patient information. But anytime that the algorithm was used, they saw a decrease in systolic blood pressure of 8.46 millimeters of mercury. And lastly, anytime a medication history was performed with the patient, whether that be with a nurse or a pharmacist, they saw a decrease in systolic blood pressure of 8.28 millimeters of mercury. They did the same thing looking at diastolic blood pressure and found that anytime a referral was made to a specialist, which was usually a nephrologist or a cardiologist, they saw a decrease in diastolic blood pressure of 19.61 millimeters of mercury. And these referrals were recommended by either the nurse or the pharmacist due to specific patient factors that they identified. They also found that anytime a patient was educated about their blood pressure medications, there was a reduction in diastolic blood pressure of 17.6 millimeters of mercury. Again, anytime a medication history was performed, they saw a significant decrease in diastolic blood pressure this time with a reduction in 7.27 millimeters of mercury. And then they also then looked at any time a pharmacist performed any of these interventions that I mentioned, or when a nurse performed any of these interventions, they wanted to see what the change in diastolic blood pressure was. And as you can see from this slide, it was relatively similar. So they saw a change in diastolic blood pressure of 4.03 millimeters of mercury when a pharmacist was on the team, and then also a decrease in diastolic blood pressure of 3.94 millimeters of mercury when a nurse was included in the team. So relatively similar change there. They also saw the same trend when they looked at systolic blood pressure. So in conclusion, the results of this meta-analysis showed that team-based care was associated with improved blood pressure control and then also allowed for better implementation of the new hypertension guidelines. Some considerations to keep in mind is that because this was a meta-analysis, there were some large differences in the duration of the interventions that took place in these studies. So some of the studies were only done for about a month, and then some of the studies were done for several years. So we do have to keep that in mind. There was some heterogeneity there. Also, there were variable sample sizes and dropout rates between the studies, again, just due to the inherent formulation of these meta-analyses and how they're performed. And then most studies did not include information on training for these interventions, so that can affect reproducibility in your own clinic if you're not exactly sure how the health professionals were trained to implement these different interventions in the first place. And then most studies only included either a pharmacist or a nurse working with a physician. And although this isn't really a limitation, it's just something to keep in mind because the authors did note that they felt if you included all three disciplines on the team, pharmacy, nursing, and physicians, that you may even get further reductions in blood pressure control by adding on all three together. So that's something to keep in mind, that in this meta-analysis, there was not a study that included all three disciplines working together. There was one study that looked at cost effectiveness of adding a pharmacist to the team, and they saw that due to reductions in ER visits and reductions in hospital admissions, when you included a pharmacist on the team, there was approximately about $100 decrease in the amount that it took to decrease the patient's blood pressure by 1 millimeter of mercury. So what that means is by decreasing a patient's blood pressure by 1 millimeter of mercury, if you had a pharmacist on the team, you could save $100. So if you think about those numbers that we saw with the reduction in systolic blood pressure, anywhere from like 21 based on the interventions to 8, then you could save about $800 or $2,100 for that one patient by reducing ER visits and hospital admissions when the pharmacist was a part of the team. The next study that I wanted to review was a quasi-experimental study published by Lazier et al. And the title of this study was Effects of an Interdisciplinary Education Program on Hypertension. This was a pilot study, and the aim was to examine the effect of an interdisciplinary educational program on blood pressure control. This study was performed in Canada and was published in the Canadian Journal of Cardiovascular Nursing. There were 2 arms in the study, and patients were either randomized to the intervention group or the regular care group. So the intervention group had a sample size of 21 patients, so relatively small, and these patients attended 4 weekly interdisciplinary education sessions about hypertension, whereas the regular care group, which had a population size of 19, were treated simply by seeing their primary care physician in their clinic. The target population for the study was men and women aged 20 to 70 years old with a blood pressure greater than 140/90 in clinic on 4 occasions, or greater than 135/85 in the community on 4 separate occasions. Participants needed to be fluent in French to participate in the study, and then also had to receive no additional education on hypertension or the risk factors associated with hypertension beyond the information that they were given by their primary care provider. They also had to be capable to participate in the education program. Some exclusion criteria included those with diabetes, cardiovascular disease, renal disease, pregnant women. So this study was performed in relatively healthy patients. The primary outcome of this study was a reduction in systolic blood pressure, which was measured using a digital blood pressure monitor. Some secondary outcomes included changes in knowledge, which they measured using a questionnaire. They also looked at changes in BMI, waist circumference, medication compliance, changes in lifestyle, and also changes in quality of life, which they used the SF-36 survey to assess. Follow-up occurred by measuring blood pressure at baseline, at 1 month, 3 months, and then again at 6 months. So to go into detail a little bit about what that intervention arm really looked like, essentially the patients in this arm attended 4 different educational sessions, lasting 1 to 2 hours in duration. The first session was led by a nurse practitioner who discussed an overview of hypertension, risk factors, and instructions for self-monitoring blood pressure. The next session was performed by a dietitian who went over the DASH diet, which is Dietary Approaches to Stop Hypertension diet. And the third session was conducted by a physiotherapist who gave recommendations on physical activity and exercise. And then lastly, the participants attended a session that was performed by a pharmacist who discussed the pharmacological options for hypertension, potential side effects to be aware of, and the importance of medication adherence. The results of this study found that the average reduction in systolic blood pressure in the intervention group was 10.8 millimeters of mercury, greater than the reduction observed in the regular care group. So they found that this interdisciplinary education model significantly increased the reduction in systolic blood pressure. In comparison to the regular care group, participants in the intervention group also appeared to be older. They had their diagnosis of blood pressure for a longer period of time. They also tended to be heavier in weight and then also less physically active and had lower levels of education. Although none of those differences were statistically significant, this is something to keep in mind when analyzing the results because at baseline, the patients in the intervention group were a little sicker, therefore they had more room for improvement than the control group. But with that being said, after they adjusted for those differences, the greater reduction in systolic blood pressure in the intervention group versus the control group still persisted. Now, they did not find a difference in diastolic blood pressure that was statistically significant in this study. And they also found no statistically significant differences in those secondary outcomes that I mentioned previously. Some limitations to keep in mind for this study is the small sample size, which can potentially limit generalizability. In addition, the data collectors were not blinded, so there may have been some bias, and several of the components of the study, such as adherence, was self-reported by the patient, so there's also potential for bias there. And participation in the education program was actually not associated with an improvement in hypertension-related knowledge, which was assessed using a questionnaire. So essentially, patients took this questionnaire at baseline and then after the intervention, so after attending the educational sessions, and they did not find improvement in scores. But they also noted that some of the patients tended to be well educated, so they thought that maybe there was an underestimation in the effect of this intervention on knowledge improvement. Nevertheless, the authors did conclude that an interdisciplinary approach to educating patients about hypertension may be effective to reduce blood pressure. And I think this study shows that when you include different professionals from different disciplines coming together to talk about the same topic, patients can benefit from learning from things, different perspectives in different ways, and it can sort of hone in the point and then also lead to better blood pressure control. The last study that I'll review is a non-randomized retrospective comparison study written by O'Neill et al. Titled Collaborative Hypertension Case Management by Registered Nurses and Clinical Pharmacy Specialists within the Patient Aligned Care Teams, or the PACT model. This was published in the Journal of Internal Medicine in 2014, and it took place in a VA medical center. The aim was to compare pharmacists and nursing team versus a physician and nursing team for patients with poorly controlled hypertension. So this study reviewed the medical records of patients who saw a nurse for their hypertension, as well as either a physician or a pharmacist between the time periods of May 2011 to November 2011. There was a pre-specified sample size of 63 participants in each group, and the study included both face-to-face and phone visits, which we'll talk about a little bit later, but I think this is a positive because the phone visits tend to be a little bit more convenient for the patients. But patients were excluded if neither a physician nor a pharmacist was listed as the provider at their index visit. So essentially, if they didn't see a physician or a pharmacist and they only saw the nurse, they were excluded from the study. And then if they displayed non-adherence to treatment or follow-up, they were excluded, as well as if the patient was enrolled in home-based primary care. The primary outcome was the difference in systolic blood pressure between the two groups. Therefore, blood pressure was measured at the index visit and at the next consecutive visit. In the case of the telephone encounters, they took the average blood pressure reading of their home blood pressure monitoring results. And then even if they saw a patient in clinic, if the patient had known white coat hypertension, they also allowed the use of home blood pressure readings that they took an average of. Out of the 184 patients that were evaluated for this study, 126 were included. So they met their pre-specified sample size of having 63 patients in the pharmacist group and 63 patients in the physician group. The demographic characteristics between the two groups were generally similar. Patients in the pharmacy group had a greater average decrease in systolic blood pressure compared to those in the physician-directed group, which you can see here on this slide, but the groups did not differ on measures of diastolic blood pressure change. At follow-up, the number of patients with blood pressure of less than 140/90 were similar between the two groups as well, and they performed a multivariate regression model for controlling for confounding variables, which found no significant effect on pharmacist versus physician-directed team on systolic blood pressure change. So essentially, they did not see a significant difference between a nurse working with a pharmacist and a nurse working with a physician when it came to reduction in blood pressure. So again, the conclusion, they did see similar blood pressure reductions, which occurred in the pharmacist-led group versus the physician-led group, and both of the arms included a nurse on the team. So they concluded that adding a pharmacist and a nurse to the team with a physician can increase access to care for patients, and this can include both face-to-face and phone encounters. Now, some limitations of the study to consider is that the study used the blood pressure goal of less than 140/90, part of which is due to when it was published. Because the study was retrospective, it can only be considered exploratory due to the study design, and then also the data that they were able to use is limited to what was previously documented. So there may be some missing data or missing information that we would have liked to have known. And then lastly, because it took place in a VA health system, this can limit generalizability to a sense because of the resources that are available at the VA, as well as the common characteristics of the patients that are generally treated in the VA system. So now that we've reviewed some of the data to support using a team-based care approach for the treatment of hypertension, I wanted to spend the rest of my time talking about our interdisciplinary hypertension team at the UF Health Internal Medicine Clinic at the Medical Plaza. We started this team a few years ago before my time here as a resident, but I did want to go over what these clinic visits look like and who all is included on our team, as well as review some preliminary data we've collected for the patients that have been seen in our clinic thus far. So how did this clinic even get started in the first place? Essentially what happened is the first step is they identified a need. So using our electronic health record, they identified that there was a large proportion of patients who were above their blood pressure goal. So they knew there was a need to better treat this population. We also have had interdisciplinary teams in place here previous to setting up the hypertension team. So we use those successes as an argument to create another interdisciplinary team for the treatment of hypertension patients. So here at this clinic, we have a diabetes clinic, which is run by physician team, pharmacy team, and nursing. We also have the transitions of care clinic, which is designed for patients who've recently been discharged from the hospital as a way to prevent hospital readmissions. And this team includes nursing, pharmacy, physicians, social work, and home healthcare agencies. And lastly, we have this anticoagulation clinic established here, which is pharmacy and physicians working together. So the successes that we found in those different clinics helped make the argument stronger to set up this clinic. And lastly, the proper personnel was already in place. So there's a pharmacy team here that's present Monday through Friday, a clinical pharmacist, pharmacy resident, and then also pharmacy students on their ambulatory care rotation here. So a lot of different people working together. And then also the RN health coach, Sally Walker, is here Monday through Friday. So we already had the proper personnel to set a clinic like this up, in addition to the physicians who are here every day too. So because of that, it made it a little bit easier to get this going. Now, like I mentioned, our hypertension team consists of a registered nurse, which is our RN health coach, pharmacy team, pharmacy student included in that team, and then also physician. So these appointments are extended to 1 hour long appointments. That way they can spend their time talking to each of the disciplines in depth and not feel rushed. And this also allows time to really focus on all aspects of hypertension, include non-pharmacological and pharmacological interventions. I will mention that patients tend to like the fact that these are 1 hour appointments because they feel like they're taking time out of their day to come see their doctor, and they're getting maximum benefit because they get to see nursing, pharmacy, and physician all in one visit. Now, generally speaking, patients are referred to our hypertension team here by their primary care physician who's also in our office. So the primary care physician tends to refer patients to our clinic, mostly for patients who have resistant hypertension. So these are patients who are on 3 antihypertensive medications at maximally tolerated doses and are still above their blood pressure control. We also tend to see patients who have very labile blood pressure, so they're very sensitive to changes in their medications, and then also patients who have adherence issues because they could benefit from having a visit that is specifically focused on hypertension. So just to go into a little bit of what each visit looks like, the patient is put into one of our exam rooms and their blood pressure is taken. They get to talk to the RN health coach first, who goes over a lot of lifestyle modifications such as tobacco cessation, diet, so low sodium diet, also exercise, stress reduction, a lot of different things depending on what the patient can benefit from the most. And because that takes a little bit of time of the visit, the RN health coach then gets a repeat blood pressure since the patient's been sitting and relaxed for quite some time. Then the pharmacy student goes in and sees the patient and conducts a medication review. And then also, if we know that adherence is an issue for the patient, we will call and do a refill history with the patient's pharmacy beforehand. So we have a good idea of what the patient has been filling from their local pharmacy, which can help guide the interview a little bit depending on what you find out. The pharmacy student will come and present to the pharmacist, and the pharmacist and pharmacy student together will go in and see the patient, come up with a treatment plan that the patient is agreeable to, or discuss different treatment options that the patient might be agreeable to. And then the pharmacist and the physician work together to come up with a final treatment plan based on what's best for the patient. The pharmacist and physician go and see the patient together. So that's the last step. And the physician is there to sort of relay information for the final treatment plan, to assess the patient appropriately, and be there as a resource for any questions that the patient might have towards the end of their visit. So all 3 of the disciplines, nursing, pharmacy, and physicians, are equally involved in the visit to come up with a really good plan for the patient when they walk out of the door. Now, after their first visit with us, we do conduct follow-up visits in clinic and by phone. So I mentioned this earlier when I was reviewing one of the previous studies, but the phone follow-up, especially given the current concerns with coronavirus, has been really helpful because there's been some data to show that patients who have uncontrolled hypertension, if they do end up getting the virus, tend to be a little bit more sicker. So these are patients that we for sure want to give a lot of attention to right now to make sure that we're getting their blood pressure controlled. And even pre-COVID, we were doing phone follow-up because the patients tend to like having the convenience of being able to call in and report their blood pressures. And if we need to make a minor change, we can do that using the RN health coach, pharmacist, and physician all together for a phone call follow-up. But most of the time it will be in clinic. It's just we do have that phone follow-up option as well to facilitate in between clinic visits if needed. So just to go over what each discipline focuses on, the RN health coach focus tends to be on lifestyle modifications, so weight loss, healthy diet, reduction in intake of dietary sodium, also enhanced intake of dietary potassium for specific patients, physical activity, and moderation in alcohol intake, as well as tobacco cessation. So this chart comes from the 2017 American College of Cardiology and American Heart Association hypertension guidelines to show some of the most evidence-based lifestyle modifications to recommend for your patients. I like this chart because it includes how it can impact systolic blood pressure in patients who have hypertension, but then also in patients who don't have hypertension. So it's a good reminder on how these changes can impact blood pressure just at baseline. The pharmacist focus is going to be on guideline and evidence-based pharmacological recommendations in guidance with the physician, of course. So the pharmacist can also order lab work to assess kidney function and electrolytes depending on the medications that the patient's on. So if we're going to be starting something like a diuretic or an ACE inhibitor or an ARB, then monitoring kidney function would be extremely important. So we're able to order those labs and then monitor accordingly. We also perform the medication reconciliation, like I mentioned, so making sure you're going through really thorough line by line and assessing over-the-counter use and herbal supplement to see if there's anything that the patient might be taking that could be affecting their blood pressure as well. We also discuss different adherence techniques based on what the patient struggles with the most. Sometimes that just includes leaving a note by your coffee maker if you take your medication in the morning to help you remember. Sometimes it includes a pill box. There's a lot of different strategies and techniques that we can offer. And then, of course, side effect counseling for any new medication that we might be starting or increasing the dose on would be important so the patient is aware of what to look out for. So I wanted to spend a little bit of time going over some of the preliminary data from our hypertension team here at the UF Health Internal Medicine Clinic, using the population of 30 patients who've had at least 2 visits with us here at the hypertension team. And this did include phone call follow-up. So it could have been that the patient saw us once here in clinic, and then we called them for their next follow-up. So it was just a minimum of 2 visits, and it could have included a phone call follow-up. On average, at their first visit with us, their blood pressure was 147/80 millimeters of mercury, and then at their most recent visit, a blood pressure of 132/74. So just almost at that goal of less than 130/80, and I'm pretty proud of that average reduction of 15/6 millimeters of mercury, especially considering that a lot of these patients tend to be in that resistant hypertension population. So really any reduction in blood pressure is a win. So looking at these numbers, I think you're seeing a promising effect on blood pressure by including a nurse and a pharmacist and a physician on the same team for patients who have hypertension. Just to go into a little bit more results, just to look at the average number of antihypertensive medications patients are on at their first visit versus their most recent visit, you can see that that number increased from 1.8 to 2.2. So we are increasing the number of medications that patients are taking. But this doesn't necessarily include the number of medications that the patient was prescribed. So we might notice that a patient was prescribed 4 different antihypertensive medications. They come to see us and we find out that they're only taking 1 of them. So that's something that can commonly happen, and that might be why this number is a little bit lower due to adherence. And then the most common interventions that we make pharmacologically include adding spironolactone as a 4th-line agent and monitoring appropriately. Also switching from hydrochlorothiazide to chlorthalidone, which is preferred due to its longer half-life and proven trial reduction of cardiovascular disease. Chronotherapy is another new tool that we're using with ACE inhibitors and calcium channel blockers. And the idea is that in the resistant hypertension patient, there seems to be a large proportion of patients who do not get a normal nocturnal dip in their blood pressure while they're sleeping. So for patients who are normotensive, they get about a 10 to 20% reduction in their blood pressure when they're sleeping. That way, when they get their morning surge of blood pressure, the blood pressure tends to be sort of back to their baseline. What they found is that up to 70% of patients in the resistant hypertension population do not experience that 10 to 20% decrease in their blood pressure overnight. So if they don't get the reduction and they still get the morning surge of blood pressure in the morning, they can get really high readings first thing in the morning, which can affect blood pressure control throughout the day. So there's been studies out there to show that moving an ACE inhibitor or calcium channel blocker to nighttime dosing, number 1, can help with side effect profile if they're sleeping through some of the side effects. And then number 2, can help get that decrease in blood pressure in the evening, which can help improve blood pressure control throughout the day. So that's an intervention to think about in a patient who maybe cost is a concern or adherence is a concern. So for example, they are supposed to take everything in the morning, but they just forget to take it in the morning. This is a strategy that you can employ to try to help improve adherence by moving something to bedtime. And then also if the patient does have uncontrolled blood pressure, but they're unable to afford another copay for another medication, then moving something to nighttime is a way to sort of maximize their current regimen without adding on another cost. And then another really common intervention that we make is stopping NSAID use. I would say probably about 50% of the patients that we see in the hypertension team use NSAIDs, and that could be sparingly or every day, but not a lot of patients are aware of their effect on blood pressure, kidney impairment, and fluid retention. So this is a huge intervention that we make quite often. And in fact, there's one patient that I can think of that we added spironolactone as a 4th-line agent, still could not get the blood pressure under control, and then identified that she had been using over-the-counter NSAIDs, so asked if she could switch to something that is less likely to affect blood pressure, such as topical agents or something like Tylenol, and then she was able to get her blood pressure under her goal of less than 130/80 by cutting out NSAIDs. So this can be a significant intervention that is also not associated with a copay that can help your patient reach their blood pressure goal. So just specifically looking at the patients who we've performed chronotherapy in, so patients who we've moved either the ACE inhibitor or the ARB or the calcium channel blocker to nighttime dosing, this occurred in 5 patients out of the 30 patients that we looked at in our preliminary data. So about 16% of the total population in the patients who've seen us twice. The average blood pressure at their first visit was 148/80, and then average blood pressure at the most recent visit was 132/72. So again, you can see that this intervention alone can have significant impact on blood pressure and not associated with another copay. It's not necessarily something that we would consider a first-line recommendation, but it is something to consider in the resistant hypertensive patient who is on a lot of different agents already, and you're still trying to get blood pressure control to maximize what they're currently on. Now, I think if you have the best team in place, but the patient buy-in isn't there, then you're not going to see great results. So I did want to include some of the patient testimonials from patients' experiences with our clinic. So these are 2 quotes from patients. The first one reads, "This clinic keeps me focused on what I need to do to better control my hypertension." And the second quote reads, "I can tell you all really care about my well-being. Your compassion motivates me to take better care of myself." So these are quotes from patients that I think highlight their positive experience with our team. Even though it's a longer visit, their positive experience getting to see a nurse and a pharmacist and a physician, they feel like they're really getting maximum care, and we're all working together to come up with a goal and the best treatment option for that particular patient. So when you get patient buy-in, they tend to be more willing to make the changes that you recommend, but also willing to make lifestyle modifications, which is just at the end of the day going to benefit the patient. So to conclude on our hypertension team at the Internal Medicine Clinic, as you can see, this data does show success in reducing blood pressure after at least 2 visits with our team. The extended visits do allow for focus on lifestyle modifications as well as pharmacological interventions, and the interdisciplinary approach is an effective way to achieve blood pressure goals. Some future aims for our team here at the clinic is to improve and coordinate the referral process. So one thing that we really want to work on is the first time the patient comes to see us, we have all the information we need. So maybe that's doing a refill history for the patient before they come in the door, or maybe that's ordering labs to have before their first visit with us so that we have all the information we need to make the best treatment decision. So making sure that we have all of that set up before their visit can help sort of coordinate the process. Another thing we want to do is reduce the rate of no-shows, which I think every clinic is trying to strive to do. And then ambulatory blood pressure monitoring, so 24-hour blood pressure monitoring is an area that we are exploring as well. And then we also want to look at formally assessing patient satisfaction using a questionnaire to better identify how well patients receive our treatment recommendations and how well they receive our team in general. But a conclusion for my entire presentation, I think you can see here that the typical primary care setting time limits, comorbidities of these patients, and also inadequate follow-up are all barriers to effective blood pressure management. The guidelines do recommend a team-based care approach to achieve a blood pressure goal of less than 130/80, and pharmacists, nurses, and physicians and other healthcare providers can work together to improve patient outcomes. And lastly, the preliminary data from our hypertension team does show promising reductions in blood pressure, so we are excited about that. Now, I did want to acknowledge Dr. Catherine Vogel-Anderson and Sally Walker, my partners in the hypertension team, as well as Dr. Melanie Hagen, our physician champion, and Dr. Ryan Nall for the opportunity to give this webinar today. And with that, I will open up the floor for any questions.
So a great presentation. Thank you very much. I do have, I'm wondering, for someone who is not currently doing this, what's the one most important bit of information or recommendation you would have for them?
For starting this all together from scratch, I think just having a team that is ready to work together is a really good first step. So because we have everyone here in the same clinic location, so pharmacy, nursing, and physician here every day, Monday through Friday, that has made this clinic, I would say, the easiest part of setting it up because the personnel is already in place. So I just think having a way for you all to work together in the same location is a really good first step. And then also having a good way to identify patients who would benefit most from seeing an interdisciplinary team. So whether that's looking through the electronic health record to identify patients who, maybe their refill or their, again, their medication list, you can sometimes identify patients who might be overdue on their medications and also have high blood pressure. So just really toning in and finding the best population that you want to target first would be a good recommendation for starting this clinic. And I can also open that up to Dr. Vogel-Anderson or Sally, as they were here when the hypertension team was created, if they have any other additional recommendations for where to start.
Rachel, I think you hit the nail on the head, but what I can say that I've learned through my time at the Med Plaza is just that it's so much easier to share the decision, not just with the patient, but with our team. And so I really can't express enough how grateful I am for the opportunity to be at the Med Plaza, where I have so many great people to work with, like Sally, our RN health coach, and then Dr. Hagen. So it's really been beneficial to our patients, but professionally as a pharmacist, it's just been so nice to be able to manage these patients as part of the team. So I'm not all by myself making this decision, which they're hard decisions to make, right? And so I think having a great team has been the secret to our success for sure. So I'm very grateful for that.
Are all of your patients referred by the physicians that work within that team?
Yes, so for the majority, it's patients who their primary care physician is at our specific internal medicine clinic at the Medical Plaza. We have recently just started to expand out to primary care physicians who work at our sister clinic, the Spring Hill Clinic. So we have one patient enrolled in our hypertension team who their PCP, their primary care physician, is located at the Spring Hill location, but they come to see us to see the hypertension team. And we communicate with the PCP through our electronic health record to keep them updated and in the loop about the treatment decisions that we're making. But when the patient comes to see us here at the internal medicine clinic at the Medical Plaza, they still get to see a physician as well. So I guess I should have mentioned that or cleared that up, that every time a patient comes to see us, it's not necessarily their primary care physician who is the physician involved in the visit. Sometimes it's another colleague here at our clinic.
What has been the biggest surprise that you all have found doing this? What surprised you the most?
For me, I would say the biggest surprise is how scared patients are of low blood pressure versus high blood pressure. I have noticed from my time here that patients are a little bit hesitant to be aggressive in treating their blood pressure because they're worried about things like dizziness and falls, which is definitely something that we want to keep in mind. But high blood pressure can be dangerous too and can increase the risk of stroke and heart disease and myocardial infarction. So a lot of the times patients, I think, associate low blood pressure as being scarier than high blood pressure. So just really kind of redirecting that and making sure that the patient is comfortable with the plan, of course, but also highlighting some of the dangers of having an elevated blood pressure has been something that I wasn't really maybe necessarily expecting from patients who have hypertension, because these are patients who, for the most part, have had it for a really long time. So I would have thought that maybe they were a little more familiar with some of the complications of high blood pressure. But to me, the biggest surprise has been how scared or reluctant they are to having a blood pressure of less than 130/80 compared to, maybe what they're more used to, like where they might have been before they started these medications. So to answer your question, I would say the biggest thing that surprised me is how scared patients are of having low blood pressure versus high blood pressure.
I think one other thing we learned is that often, well, I shouldn't say often, but it's happened enough that I feel like it's often that we'll talk to patients about, oh, you're taking an NSAID every day. Why are you taking it? And then we've had a couple patients say, oh, I just thought I should take it. Should I not be taking it? And we're like, well, no, if you're not having pain or anything, no, you don't need to take it. And in fact, it could be making your blood pressure worse. And then they're like, well, then I'll stop taking it. And, that's such a small thing, but it has been impactful to me anyway, because I think sometimes I forget about asking about all the OTCs and herbal supplements. I mean, the list goes on. And so I'm always happy when a patient is willing to stop taking NSAIDs. However, I don't mean to minimize the pain that our patients have who absolutely need NSAIDs, but I guess it's just encouraging to know that sometimes you actually can successfully stop Aleve or ibuprofen, and it actually works. I think Rachel probably has 10 more stories along those same lines. So we've been pleased with some of those interventions as well.
Do you provide your patients a blood pressure monitor?
So we don't provide blood pressure monitors. We talked about that as some options as part of what we could offer patients, but we do have the 24-hour ambulatory blood pressure monitor, which I didn't speak too much about, but we have one that we can lend out to patients to use for a 24-hour period to measure their blood pressure. And this is for patients who you may suspect pseudo-resistant hypertension, or you might suspect white coat hypertension. So that is something that we can provide them for a short-term basis that they then provide, or they bring back, sorry, after the 24-hour period.
Because what I find out is a lot of our patients say they cannot afford it, so our clinic has been providing blood pressure monitors to patients.
Yeah, I think that's amazing, and I wish we could do that for all patients. And so we try to get creative about ways that they could check. So do you have a friend that has a blood pressure monitor, or can you go to Publix or CVS to use one there and write down the value when you're out and about? So sometimes we do have to get creative because cost is an issue.
Okay.
Any more questions that anybody has? I'm very patient. Oh. I want to give anybody a chance. Still processing stuff, maybe. All right. Well, I guess we will wrap up then. So thank you all very much for a great presentation. And
thank you for having me.
You're very welcome.
Gianna, do you need anything else from us before we go?
Nope, we should be all set.
Okay.
All right.
Thanks.
Thank
Thank
you,
you,
Gianna,
everybody.
for setting it up. Appreciate it.
Thank
Bye.
you all so much. Thanks. Great job, Rachel.
Thank you so much. I see someone said go Gators in the chat box, so go Gators.
I know. Go Gators.
All right, bye everyone.
Bye. Thank you all.